Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Ankur Ahuja from AFMC Pune, and he's going to lecture us on Pancytopenia Unmasked, a case-based journey through diagnostic pitfalls and complex scenarios. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Lucian Life Sciences, and very well managed by Perfect Square. I thank Mr. Srivastav and Team Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Ankur Ahuja from AFMC Pune. All our discussants were themselves very eminent hematologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 22nd of March 2026, from 11:30 a.m. Indian Standard Time, we have again Dr. Ankur Ahuja from AFMC Pune speaking to us on unraveling eosinophilia, case-based insights into common, rare, and missed diagnosis. Let me introduce our discussions for the day, and they are well displayed in alphabetical order. I will pause for a while for you to look at all our discussions for the day for very eminent hematologists, hemato-oncologists, as well as medical oncologists and hematopathologists all across the country. Some more over here. So these are our discussions for the day, and now it's time to introduce our guest speaker for the day. We have with us Dr. Ankur Ahuja from AFMC Pune. Let me introduce Dr. Ankur Ahuja to all of you. Dr. Ankur Ahuja is MD, DM in Hematopathology, Professor, Department of Pathology at AFMC Pune. Dr. Ankur Ahuja is a very distinguished academic hematopathologist with DM Hematopathology from AIIMS, New Delhi. He is currently serving as professor at the Armed Force Medical College, Pune, where he is actively involved in diagnostic service, teaching, and research. With deep expertise in bone marrow pathology, hematolymphoid neoplasms, and benign pathology, he is widely recognized. He has authored 96 peer-reviewed research publications in both national as well as international journals and has contributed 13 chapters to standard textbooks of pathology and hematology. He is an accomplished poet and has received 3 awards for excellence in poetry writing, reflecting a blend of science and the humanities. In recognition of his professional dedication and clinical excellence, he has been awarded 3 commendations for distinguished services as a doctor. He is also a sought-after speaker, moderator, and mentor in academic forums. Today, he is with us and is going to lecture us on Pancytopenia Unmasked, a case-based journey through diagnostic pitfalls and complex scenarios. Well, thank you so much. I stop over here. Over to you, Dr. Ankur Ahuja. You're muted, Dr. Ankur.
At the outset, sir, thank you, Mr. Amir Agarwal, sir, and the entire MSG team for inviting me to share my experiences on the topic Pancytopenia. I'm really honored to be in this platform, sir. I'll just share my PPT. Sir, is it visible, sir?
Not yet. Yes, now it's visible. You can put it in full screen mode.
Yes, sir.
Perfect. Please go ahead.
Sir. Thank you, sir. So basically, the topic Pancytopenia, what is it? So the RBCs, WBCs, platelets were merrily together, and one day they started falling. And the reason, a puzzle which was visualized to us, but not to our mind. And that's what we have to train our mind to look upon those aspects, those hidden puzzles also. The topic Pancytopenia Unmasked, case-based journey through diagnostic pitfalls and complex scenarios. My lecture journey will be some discussion about the definitions, some aspects about the pancytopenia, and I'll go through some various cases which I have encountered in my during my practice. So in pancytopenia, the key is in the marrow, the smear, and the mind that connects them. So what is the definition? So we define when the hemoglobin is less than 12 gram per deciliter in women, 13 in men, WBC is less than 4,000, ANC less than 1,800, platelets less than 1,50,000. However, we should remember some spurious causes also. These spurious causes are can be hemodilution, clotted sample, and EDTA-induced clumping of WBCs and platelets. So what are the true causes of pancytopenia? If we go through the journey, it is acquired. And in acquired, we have a bone marrow infiltration, whether it's by non-malignant causes, including infectious, storage, granuloma, crystal deposition, and various malignant disorders. However, some aspects to be remembered is that most of the acute leukemias, they present with the pancytopenia, but they can be high TLC raised count also. And there may be some in like in AML M4, M5, the platelet counts are preserved. And in multiple myeloma too, the commonly platelet counts are preserved. However, in other, most of the malignancies, especially the APML, the acute leukemia, among the acute leukemias, it present with a pancytopenic picture. In the bone marrow failure, we have immune destruction, suppression, which includes aplastic anemia, medications, large granular lymphocytic leukemia, autoimmune disorders, HLH, and various common nutritional disorders like megaloblastic, excess, the copper deficiency, zinc toxicity, the malnutritions, the marrow suppression because of viral, most commonly the HIV, hepatitis B, C, and Epstein-Barr virus, and infective hematopoiesis because of, again, megaloblastic anemia, MDS. We have a destruction, sequestration, distribution causes, which includes consumption of like in DIC, splenomegaly, the portal hypertension, infections, autoimmune disorders, malignancies, myelofibrosis, storage disorders. And there are some rare congenital disorders, which include the inherited bone marrow failure and the congenital HLH and the GATA2 deficiency. So when we are aware of the causes, we should be knowing about the history and physical examination also. And most commonly, we should rule about the drugs and which includes allopathic as well as alternative medicines also. I keep on telling, we have encountered so many patients when we ask the drugs, they just mention about the allopathic drugs. For them, the alternative medicines are not the medicines actually. So we should take the history of the alternative medicines also, and the excessive zinc, which is a very common nowadays to have a mineral supplements and all those things. So these can also lead to the pancytopenic picture. The infections, we have already seen a lot of virus, parasitemic and fungal infections are there. Mycobacterial tuberculosis is also one of the common. The nutritional vitamin B12, and if there are some rashes, bone pain, we should think of autoimmune disorders. If there are any dysmorphic features, we should rule about the inherited bone marrow failure. And there are constitutive symptoms of like B symptoms. We should think of lymphoma and leukemias also. The Fanconi anemias generally have a family history, so we should especially the pancytopenia is there in the children. We should rule about the family history. There are some physical features we already know about those things. Similarly, with the dyskeratosis congenita, the nail dystrophy, oral leukoplakia, the Shannon-Diamond syndrome, the neutropenia, the GATA2, in which the recurrent infections are there, which leads to pancytopenia, the monocytopenia. In fact, the monocytopenia among the pancytopenia is seen in GATA2 and hairy cell leukemia. So one should think about those things also. When we go into the examination, in the general examination, yes, pallor lymphadenopathy rules about the NHL, the local examination, petechiae ecchymosis for the APML DIC, systemic examination for the hepatosplenomegaly, for various causes we have already seen in which splenomegaly is there. The signs of chronic liver stigmata like palmar erythema, flapping tremors. We should think about the hepatitis causes leading to the acquired aplastic anemia, the oral ulcers, skin hyperpigmentation. Must look for the inherited bone marrow failure syndromes. Coming to the lab investigations, if we see the RBCs, macrocytosis is not only seen in megaloblastic anemia, it's also seen in MDS aplastic anemia when we are dealing with the pancytopenia. Similarly, if we are finding the NRBCs, teardrop RB cells in the peripheral blood smear, we should think of myelofibrosis, myeloptosis, schistocytes, and MAHA-DIC, the WBCs. In WBCs, if we are finding blasts, dysbiosis, the MDS leukemia, and I just want to mention that most of the cases are pancytopenic, and like a usual routine where we examine the peripheral smear in the body, we should look upon the tail also to look for those abnormal cells or the blast cells. And similarly, phagocytosis. The phagocytosis commonly seen in the bone marrow. However, we have seen cases in which we can give an indication that we are dealing with a HLH also if we are having a typical picture of a HLH and we are finding some increased phagocytosis activity in the, by the neutrophils or the monocytes. Similarly, the reticulocyte count is also very helpful, which we often ignored in our routine clinical settings. It's reduced in aplastic anemia, MDS, megaloblastic anemia, chemotherapy. However, it is increased in autoimmune disorder, hypersplenism, marrow infiltration. So one test can at least differentiate many of the causes, which is reticulocyte count. Similarly, in biochemistry test, we have LDH, bilirubin. We know that megaloblastic anemia has a ineffective erythropoiesis, hematopoiesis, which leads to the destruction of the RBCs and leading to the increased LDH and bilirubin. The vitamin B12 folate also leads to the reduced in the megaloblastic anemia, increase in the myeloproliferative neoplasms. The LFT, RFT, thyroid panel, they all help in some or other uh, clinical scenarios like autoimmune. If there is abnormal LFT, we should think of viral hepatitis, alcoholic liver disease, infiltrated disorders, HLH. In fact, in HLH, the H score, now AST has been included, and we'll discuss the significance of that also in the subsequent slides. The abnormal RFT also for the HLH, sepsis, multi-organ failure. The viral markers include the HIV, hepatitis B, C, parvovirus, and the autoimmune profile. Now, there comes the very important role of the bone marrow. When we are dealing the bone marrow, we should assess the bony trabeculae also. I keep on telling my residents also to look for the bony trabeculae also, because that's my very pretty kind of experience in which we saw an osteopetrosis case, and that case was continued for long period, was dealing with pancytopenia. Unfortunately, everyone, most of them were looking into the IT spaces, which was apparently normal. However, they were compressed by the bony trabeculae. So this is an important feature. Also, the Paget's disease also leads to the pancytopenia. Then the marrow cellularity, we all know how to calculate the marrow cellularity, the cells, and the special stains in the bone marrow, which include CD34, 117, 41, 61, which is basically to see differentiate the aplastic anemia from the hypoplastic MDS. How? We will discuss in the subsequent slides. Similarly, assessment of fibrosis by reticulin mesenchymal stain for the PMF, that is primary myelofibrosis, lymphoma, hairy cell leukemia, the assessment of the iron dysplasia, iron through pearls and PAS to rule out MDS, to exclude the infiltrative disorder through various IHCs, to identify metastatic lymphoma deposits, like, and exclude infection storage through ZN stain, GMS stain, PAS stain for tuberculosis, fungal element storage cells, and finally we reach to the final diagnosis. So in most of the cases, the bone marrow leads us to the final diagnosis. In the bone marrow, we can do various cytochemical stains also, which are now in routine practice has not done. However, they are very helpful, like reticulin stain. It grades the myelofibrosis, the mesenchymal, the grade 0, the grade 3 is through the mesenchymal, which detects the collagen that is type 1, and it rule out the overt myelofibrosis. The Pearl's Prussian blue for the iron and iron stores. For the ring sideroblast, the PAS stain again highlight the abnormal erythroid precursors, because we know that normally erythroid precursors are negative for PAS, but when they are abnormal, they are PAS positive. So we can have a clinical suspicion, the diagnostic suspicion of MDS, AML, the blocked cause positivity in the TLL or BLL, and the pure erythroid leukemia. Acid phosphatase for the TLL, the myelophosphatase, we all know that it is positive in the AML. However, AML M0, M67 are negative, and sometimes AML M5 also. Sudan Black corroborates with the MPO. We have NSE stain for the MLM4, M5. We have the TRAP stain for the hairy cell, Toridum blue for the mastocytosis, ZN for the Mycobacterium tuberculosis, the Crocott stain for the Histoplasma candida cryptococcus, the Congorate for the amyloidosis, the oil irido for the detection of the storage disorder, and the Gaucher's, especially the Gaucher's one, which is shows the vacuolated cells. The IHC in the bone marrow, again, I've mentioned that hypocellular MDS versus acquired aplastic anemia. The blast are manufactured by CD34, CD117, PD53, despotic megakaryocytes by CD4161, erythroid by CD71, CD235A. And we have acute leukemia lineages, myeloid, the megakaryocyte, erythroid, lymphoid. So we have various ICs to look upon. Even if we don't have a flow cytometry, through the biopsy, we can at least detect what kind of a leukemias we are going through. For the solid malignancy, we have the screening. If we are suspecting the solid malignancy or some deposits are there, then we should put on pancytokeratin, CK7, CK20, TTF, thyroid, PSA, ERPR, and there are some specific, if we have ruled out through the screening, we have confirmed one of them, we can confirm through the various another group of IHCs. For the infection, parvovirus, capsid antigen IHCs available. The flow cytometry again has a role in hyperblastic MDS versus the aplastic anemia. Besides to find out the minor PNH clone, the acute leukemias, the PNH, the MDS, where we have abnormal maturation patterns in form of a reduced CD13, CD16. We have a dim CD45 blast. We have a various scores, ELN score, Alberta score, which can help us in detecting MDS through flow cytometry. Similarly, we have a flow cytometry for lymphomas, CLPDs, HLH, hairy cell leukemia, blastic plasmacytoid dendritic neoplasm. We have some molecular cytogenetics technique, conventional karyotyping, especially if we have to find out large chromosomal abnormalities in MDS, AML, CLPDs, FISH, for the submicroscopic deletions, duplications, again for the same, the chromosomal breakage study for the inherited bone marrow, especially the Fanconi anemia, the array CGH for the, again, small deletions, duplications less than 100 kilobytes. It detects the cryptic cytogenetic abnormalities, clonal cytogenetic changes, RT-PCR for the molecular fusions driver, the NGS panel, which is very common now for the various MDS disorders, inherited myelophilia, HLH, and in fact, many of the list. The list is very, very long. Telomere length assay for the disc keratosis congenita, viral PCR for the infective causes. So the clinical history, the confirmation of the true pancytopenia, peripheral smear, bone marrow, we analyze the clinical detail history, go for these bone marrow, look for the biochemistry, microbiology, and we can use a second line test in form of a flow cytometry and molecular, and that's how we approach the case of pancytopenia. So I'll just come to the topic, the various case vignettes. Now, these cases which I have included, though list is very, very long, which I have encountered in my practice, but I have included very common cases today. But there were some diagnostic dilemmas which can come in a routine practice in those cases. So case one, the simplicity of a diagnosis often hides the complexity of the journey that lead to it. Means the diagnosis sometimes looks very, very simple. However, when we go through the journey, and I'm sure most of us would have encountered those scenarios, the journey was not that much simple. A 55-year-old male, a non-veg eater, progressive fatigue for last 6 months, loss of appetite, loss of weight for last 6 months. Clinical impression, obviously, the cryptic malignancy with the age, with the progressive fatigue, loss of weight, loss of appetite, or lymphoma. Pancytopenia having MCV of 100, 12 femtoliter, reticulocyte, corrected reticulocyte count was 0.5%, LDH was high, the LFT, RFT, the other biochemical tests were normal, and we see this cabot rings, velomacrocytosis, teardrop RBCs, giant neutrophils, hypersegmented neutrophils, ring neutrophils, pseudopelger abnormality. So we are very, very clear. We are dealing with what? Megaloblastic anemia, yes. Bone marrow aspiration, significant dysbiosis, as Dr. Renu ma'am also used to teach us that whenever you find odd number of a abnormal nuclear localization, nuclear loops, it is definitely dyserythropoietic. So we have megaloblast, we have dyserythropoiesis. We thought that we got the diagnosis when we excited, and though it was clinically unmatched, loss of appetite, loss of weight loss, we went further. But vitamin B12 and serum folate came to be normal. So what are the diagnostic pitfalls? Dysbiosis can be seen in other conditions. We have to correlate, we have to see. Generally, in our clinical setting, we give the therapeutic vitamin B12 shot and look for the CBC reticulocyte after 10 days, which is a peak day. And if there is no response, we go for the cytogenetics. The hypersegmented neutrophils are not only seen in megaloblastic anemia, they are seen in MDS also, they are seen in chronic renal failure also, they are seen in neonates also. So there's another, even iron deficiency anemia is also cause of the hypersegmented neutrophils. The megaloblast, sometimes they look so megaloblast that they are suspected as blast. As I've seen in my studies that my residents have confused with that also. So that thing also look upon, especially when it is a megaloblastic third hyperplasia, it reaches to 70-80%, and one confused with the pure erythroid leukemia, MLM6. However, one should quantify the proerythroblast also. Pancytopenia is interpreted as a aplastic anemia, which look for MCV. Generally, the megaloblastic anemia, the MCV is more than 110. And in the other, like MDS, the liver disorder, the thyroid, hypothyroidism, the MCV is generally between the generally less than 110. We should look for the serum B12 and folate levels. However, they may or may not be helpful because serum B12 may appear normal, particularly in pernicious anemia, because the test which we do is the binding test in which intrinsic fact we use the labeled vitamin B12 with the intrinsic factor, and there's a pernicious anemia. The serum levels of the vitamin A may be normal, or however, also in some other conditions also vitamin B12 may be normal. So we should measure methylmalonic acid, homocysteine. However, the problem is that they are not available everywhere. Similarly, serum folate, if a patient has a recently dietary intake, the folate doesn't come to be low. The peripheral smear in the early stages, it looks very good, okay. Macrocytosis, however, is the first finding to come, but still not in the very early stage is not evident. Whenever there is we in especially developing countries like us, we have a mixed anemia, iron deficiency, vitamin B12. So the microcytosis masks the macrocytosis, and we have to look for the peripheral smear in those settings. Bone marrow may get diluted. The homocysteine, because of renal dysfunction, may alter because there's alteration of the metabolism, so they may come normal also. There are other causes of macrocytosis, alcohol, liver disease, which we have to see upon. The hypersegmented we have already discussed. The elevated homocysteine can be because of renal failure. The elevated methylmalonic acid can be because of some inborn metabolic disorders. So they may lead to the false positivity. And there is a low serum vitamin B12 in the pregnancy or oral patient on the oral contraceptives because of a decreased binding proteins. Now, we have evaluated the history, clinical features, this CBC, PBS, retic count. We gave the therapeutic vitamin B12. trial. In fact, even if the patient was having normal vitamin B12 levels and the bone marrow, again, we did the pass, iron, the cytogenetics also done. And this, before I proceed further, this is basically the response. The first response is always with the reticulocyte, which comes in the 24 to 48 hours. And the macrocytosis or the hemoglobin takes 1 week. The macrocytosis MCV returns normal after 4 to 8 weeks. So we should think upon those aspects also. So the most important is the LDH, the reticulocyte peak and the response. So our patient, when given the vitamin B12, showed very good response, retic count response. So the final diagnosis was megaloblastic anemia. However, there were some unanswered questions still now. What about the significant weight loss and loss of appetite? We again called the patient to relook the history. So patient on detailed information gave that history of a chronic false smelling stools, flatulence, so stool examination was done, which want to have a GRD duodenal analysis, which answered our questions of having regular anemia despite of non-vegetarian diet, normal serum vitamin B12, because we saw the literature only 20 to 30% have the low levels vitamin B12 in the chronic GRD conditions. They have a loss of weight, loss of appetite, and those kind of a symptoms. So everything was answered when we stopped, when we didn't stop, just after diagnosis of megaloblastic anemia, we looked upon the history. However, many a times we get these kind of a pond shaped, we call it as a separated lobes, and these megaloblast also. So in case patient is not responding and we are finding very significant dysbiosis, very high dysbiosis, which also look for the cytogenetics for MDS. The causes of megaloblastic needs to be worked out. It's not that we have diagnosed the megaloblastic anemia, the cause also needs to be worked out. Every microcytosis is not a megaloblastic anemia. The hypersegmented, again, neutrophils are not always a megaloblastic anemia, can mimic vitamin. MDS can a very strong mimicker. We should go ahead with the cytochemical stains also and look for SF3B mutation in a ring sideroblast MDS. So coming to the case 2, what began as a simple fever soon became a race against uncertainty, waiting to test every ounce of our persistent vigilance and humility. This is actually from my heart, because this was a child which have seen, gone through much pain, their parents having much pain. A 6-year-old girl was admitted with a history of fever for past 2 weeks. The patient was brought 2 days back from us to us from after evaluation from the primary hospitals. The parents gave a history of a prior history of diarrhea after eating street food. Fever was intermittent with a high grade, moderate hepatosplenomegaly, pancytopenic picture, neutropenia. The fibrinogen was okay, the dimer was raised, LDH was slightly raised, blood culture showed brucellosis, AST was high. However, the other LFT was normal. We saw in the peripheral blood smear, we saw these findings. In the peripheral blood smear only, you can see there is a erythrophagocytosis and a lot of cytoplasmic vacuolations, and you can see the platelets also. This was in the peripheral blood smear. In the bone marrow, significant hemophagocytosis. They are eating the platelets also, though they are not LD bodies, which in fact at that time our resident also said the LD bodies have a perpendicular histokinate also. And similarly, not the histoplasma also. The histoplasma has a pseudocapsule. So we have a again megaloblastoid picture, the plasma cells, the hemophagocytosis, in fact, a lot of significant hemophagocytosis in the other pictures also. So many times the clinicians ask how much significant hemophagocytosis. So, however, the consensus is not that much clear. However, I just gone through some studies and made some table. So, some may count with a high the HPF, the high power focus. Some most of them actually count the cells and see how much hemophagocytosis we are getting. So significant is when we are getting 1 to 5 or in the 500 cells. So it is suggestive. However, when it is more than 5 in 500 cells, it is definitely very highly significant for HLH. And in this patient, the entire bone marrow was filled up with the hemophagocytosis. So our patient had a fever with hepatosplenomegaly, pancytopenia. We asked for the triglyceride, serum ferritin, which was raised, and we because it was child, we opted for the molecular studies also, which came out to have a FHL4 subtype syntaxin 11 mutation. So this was a confirmed. The patient, both parents had the heterozygous mutation. The patient had a homozygous variant. So in the era of NGS, we should look upon these things. In fact, in one of the ASH studies I was reading, even not in the child, also in the adulthood also, one should look for the molecular aspects also, because the primary HLH is very common, which we were thinking it's not that much. So the entire spectrum HLH protocol was given. However, we lost the patient, which was actually, and in fact, uh, 2 days back, it it would be 7 years when we have lost her. That patient even has gone, but her soul has made my mind so much impactful that I keep on telling everyone to look upon that. Whenever I see the hemophagocytosis, I don't want to lose. We lost that child. I still remember her face and smile, but I don't know. This is a learning case for us. We should not lose more patients. And the problem, the diagnostic pitfall in this case was the misinterpreting cytopenia as a marrow failure. Child inherited bone marrow failure was evaluated outside, and the time was actually in HLH, time is very limited. And in that workup for the inherited bone marrow failure, we lost some time probably. And but however, the setting condition is not that much common, so there is no blame game as such also. And must see the liver dysfunction to the infection, to that thing also. We should evaluate the, in fact, whenever we see the HLH, we should look upon for that. Many times we are being asked that look for the hemophagocytosis, that assuming that it is required for the diagnosis. I just want to put emphasis that it is absent in early in disease in 30% of the cases. So we should look upon the other HLH diagnostic criteria also. We should not over rely upon the bone marrow findings, not very specific. Many times we ignore the hyperferritinemia. Ferritin is more than 10,000, and even if we feel that other HLH criteria is not meeting it, please look upon the HLH, because ferritin more than 10,000 very strongly suggests of HLH. Whenever we fail to recognize secondary HLH triggers, we should not stop upon the HLH, the diagnosis of HLH. We should look upon the various triggers, infections, malignancies. Uh, I still remember one case of a DLBACL in which we have a lot of hemophagocytosis was there. The patient was again pancytopenia, 62 years old lady, and there was in the bone marrow there were interspersed dispersed the DLBACL atypical cells. That HLH was triggered by the malignancy, the lymphoma. We could able to appreciate those lymphoma cells, and we could save that patient, not only through the HLH but also from the lymphoma DLBCL, which we know there is a very high grade lymphoma is there. We have a soluble CD25, which is considered to be the most specific. However, it's very specialized test may not be available. So instead, one can use AST in the liver function test. That's why this is the basically HLH diagnostic criteria, which we know that fever, splenomegaly, cytopenias, triglycerides, hemophagocytosis, ferritin, soluble CD25, NK cell activity. However, many times we don't have a flow cytometry, we don't have a measure to soluble CD25. In those scenarios, we can use a H score. H score has a very better sensitivity, especially if not the specificity. So AST is very much doable in all lab standings. H score includes the AST, and rest are the other those parameters which we have. So the NK cell activity, the bone marrow requirement of the bone marrow, the soluble CD25 are being taken out. So in case of a setting where that is not available, however, this is not that much specific as compared to the we have HLS diagnostic criteria, but it's very sensitive, and especially in those settings where the resource constraints are there. So these are the interpretation guide for the H score. Now coming to the case 3, masked disease surrender their truth only to those willing to look beyond the surface. So how? We'll just look upon. A 60-year-old male presented to the OPD with complaints of weakness, fatiguability for last 3 months, 1 week episode of fever 2 months back, no history of bleeding, bone pains, abdominal discomfort. Tyler, rectus lymphadenopathy was absent. Hepatosplenomegaly was there. CT scan showed no deep-seated lymph nodes. The pancytopenic picture was there. The large atypical lymphoid cells were seen. And these were those large atypical. We can see some kind of a hairy kind of a morphology, but I just want to put emphasis upon that me and Dr. Gurpreet, we have studied a lot of, she is one of the really renowned hematopathologists, my colleague. We have studied a lot of cases, and these hairy cells are deceptive. Not only seen in the hairy cell leukemia, we have seen in SMZL, we have seen plasma cell leukemia, we have seen in the normal lymphocytes also. However, definitely, yes, they have a atypical look. Still, we are considering these hairy cell morphology. We got the trap stain done, negative. Got the flow cytometry done, ruled out the hairy cell leukemia because it had a negativity for CD103, 25, 123. However, positivity for the CD19 gated cell showed CD20 positive, CD79B positive, the FMC7 positive, the CD10 negative. The T markers were okay. No issues in that. Reticulin stain again was deceptive for us. Sometimes does look like a pericellular fibrosis, which we see in the hairy cellular. Again, we are actually at this stage, we were not sure. We repeated the flow cytometry also, which revealed the same thing. The CD20 were positive. We got the bone marrow biopsy, and all the cells were CD20 positive, and we got the annexin A1 done. Again, very confusing because at one focus, you can see that it looks like the cells are annexin A1 positive. So we also thought, are they positive? Are they actually positive? Why our flow cytometry is not supporting us? So first of all, misinterpreting villus lymphocytes, I've already discussed. We have seen in many conditions, so please don't misinterpret them. Again, annexin A1HC. They are present in T. Normally, in T cells, the myeloid precursors, they have a very strong expression, even the plasmacytoma, many epithelial cells. So instead, nowadays, double labeling techniques have been used, basically in which two ICs are being put together, one after another, matching annexin A1 with a B cell marker to look upon whether annexin A1 is present in those B cells or they are present in the T cells or myeloid precursors. So if in case any doubt, we can do BRAF V600, V1 clone, or DBA44, which is very specific and which are not seen in these normal myeloid cells. We can confuse with the other splenic lymphomas. We can use immunophenotyping for that. Again, bone marrow pattern, the reticulocytes or the intracellular pattern, again seen in many of the lymphomas like hepatosplenic T cell lymphoma also. We ignore generally the viral association. We should get done the hepatitis C infection because some SMZL cases are associated with that. And we should get cytogenetics also done because in this case, we had a deletion of chromosome 7. And again, deletion of generally whenever we say chromosome 7 deletion, we think of MDS, AML, but it is also seen in SMZL. So everything has to be integrated. So in SMZL, there is a deletion 7q, notched 2, KLF2, and absence of these anomalies does not exclude SMZL also again. I'm putting emphasis. In fact, I forgot to put up on the electron microscopic. We got the electron microscopic also done. So this case, and we got the splenic, but that would have made my slide a bit longer. So it was a case of a SMZL. So now coming to the case 4, do not envy or dazzle by the beauty of jewels or crystals. You may not know the suffering they carry within. 4-year-old male, born of consanguineous marriage, presented with failure to thrive since birth, pancytopenia, and stage renal disease, family history of sibling death with a renal failure at the age of 4 months. Again, very important history. History of similar deaths on the maternal side. Clinical suspicion at that time was the clinician, they told me to look upon the inherited bone marrow failure. Pancytopenia was the in fact we got the bone marrow, we got some surprises. That's why we go back again to see for the urine microscopic, which we found octahedral crystals, needle shaped, birefringence to polarized light, dissolved in dilute hydrochloric acid. We did all these things. Actually, we did put the dilute hydrochloric acid also. We saw the birefringence also. And in the bone marrow, this was a surprise. We got the entire trabeculae were filled up with these crystals, and that answered our chronic renal failure, the pancytopenia pictures, and there are many crystals which are seen: calcium oxalate, uric acid, triple phosphate, sustained cholesterol, hematidine, charcoteledon. So we can differentiate by the polarization. We can differentiate by their appearances. We can do the urine test, and we can do the genetic study. So in this case, again, the patient had a homozygous frameshift mutation of exon 4 in AGXT gene, which confirmed our family hyperoxaluria type 1. Both patients had a heterozygous frameshift mutation in the AGXT gene. So again, one should be very cautious because urine oxalate may be falsely low in advanced CKD disease. We should do 24-hour urine collection. We should interpret with the creatinine. We should do the glycolate or this test for the primary oxaluria 1. We should do the glycerate for the primary oxaluria type 2. The plasma oxalate, non-specific, again elevated in end-stage renal disease. So we should do the genetic testing. We should do the enzyme assays. There are many imaging and histological mimics are there for the nephrocalcinosis. So it looks very easy, but sometimes in this case, bone marrow was definitely suggestive. In fact, we got the nails also done. The nails also had the crystals deposits on it. So whenever they say, whenever it is there in the bone marrow, it is there in the each and every body part of. So whatever sample we can get, we could have got, we got those things done. And these genetic testing actually resolved most of the ambiguities, and not only the ambiguities, but we counsel the patient, and then in the next pregnancy, thankfully, the child didn't suffer from the because this child we lost. Obviously, there was no but we could not able to reach for the bone marrow transplant. I don't know. I don't have any such experience of the BMT also, whether how's the response. But thankfully after so much genetic counseling and testing before in the prenatal testing, so the second child was absolutely okay. Case 5, symptoms may whisper one story while the disease quietly writes the another one. 34-year-old presented with fever, 6 days, deep in thrombosis, 4 days, no bleeding manifestations, referred to as a case of MDS in view of pancytopenia and significant dysbiosis. We got these dumbbell-shaped cells. Very few cells were there, and most of them were in the tail. And in fact, some dysbiotic cells were also present. Got the MPO stain, which were positive. So clear-cut diagnosis of APML, teardrop pattern, occlusion wire pattern, typical seen, MPO positive, 13 homogeneous positive, 33 heterogeneous positive, the CD117 positive, the DIM CD117 positive, 34 HLA-DR negative. So typical APML. But why this case? I want to put the emphasis that we deal with so much pancytopenia that we may not we forgot to see the cells in the tail, and we sometimes uh, they are basically they lose their morphology. So is the poorly preserved are there at the smear edges, but one should not underlook for that, and uh, should have a clinical suspicion in the mind, especially even in this patient, the patient didn't present with a bleeding manifestation, in fact, which is very not common. So, in fact, the patient presented with a thrombotic manifestation. Honestly, in my 10-year experience as a hematopathologist, more, I have just seen 3 cases of thrombosis in a APML cases. So that scenario is not common, but however, our if we have a strong morphology look and we are looking the each and every aspect, we should have a suspicion of APML also. So and this is one of the thing which is very common mimicker, because they are CD34 HLA-DR negative. They also have a bilobe sometimes nucleus. However, they have a couple-like nuclei also, which is very characteristic of this, and they have a CD64 bright. The microgranular many times confused with the the AMLM5, the CD2, CD9, they can help us. And sometimes they have a CD34 partial also, the microgranular variant. However, the CD13 uniformly homogeneous seen in the APML, while it's there in the heterogeneous. And in the AML-M5, we find a homogeneous CD33 expression. The KM2 AML again present with the CD34 HLA-DR negative. We have a lot of cases. We have compiled the cases of CD34 HLA-DR, and one of these commonly is the KMT2 also. So again, we have to look for the molecular aspects also and ATRA effect sometimes, because I still remember one of the case in which we were getting a lot of neutrophils, and however, there were some frigate cells were there, so which is was contrast we have learned in APML, because that patient was partially treated and no records were available. So that ATRA effect should be in our mind always. So many times because of severe pancytopenia, we think upon aplastic anemia, because again, there is a neutropenia in this APML, so they may mimic aplastic anemia or MDS. So we should scrutinize smear for subtle promyelocytes, which are sitting in the tail or the edges, and which, if any suspicion is there, we should ask for FISH PCR for PML RARA, sepsis DIC, because they are such correlated, and these sepsis DIC, because of another reason also, they they are mimickers for the APML. The molecular variants are there. We should remember those molecular variants which have a in case we get a, because recently we got a frigates, but it came out to be fish negative. However, in the NGS revealed the other molecular variants. So we should think about those things. Why thrombosis? We have a cellular mechanisms, overexpression of tissue factor, cancer proglobulin, macroparticles, maybe treatment related, ATRA induces differentiation syndrome, the etiosis is there, like netosis, that is neutrophilus. So clinical risk factors are absence of bleeding at diagnosis, clinical risk factors for the thrombosis, the high WBC count, the presence of CD2, CD114, FLT3, ITD mutations, they have a high risk of a thrombosis. So coming to the case 6, what happens in life may happen in medicine. Some events that seem unfavorable at first may quietly become the turning point towards a better outcome. So 37-year-old, fatiguability, weakness, pancytopenia, MCV of 104, slight polychromasia, occasional NRBCs, biomarkers negative, bone marrow biopsy was low, less than 5%, no ellipse, that is abnormal localization of immature precursor cells. We got the flow cytometry done, definitely a very significant amount of a PNH clone was present, 87% present in the both neutrophils and the monocytes. So PNH clones are in aplastic anemia are common. They emerge in 40 to 70% of cases. They have a escape clones because they don't have a GPI anchor protein, so they are not attacked by the immune cells. They serve as a diagnostic marker and predictor of the immune suppressive therapy. So whenever you find a PNH clone, it strongly favors acquired aplastic anemia over inherited marrow failure. In one of the studies, it was a 69 prevalence in acquired aplastic anemia versus 5% in the inherited bone marrow failure. So larger clones correlate with the intravascular hemolysis, thrombosis risk, better immunosuppressive response, superior overall event-free post IST or HSCT, reduced chronic GVHD after transplant, clonal expansion post IST present in 48%, clinical PNH evolves if more than 50% granulocytes with the LDH. So our patient had a more than 50% of the response. These are basically laboratory evidence. If we find out, in differentiating between the small clones and the large clones, and the diagnostic dilemma is that the clones are very small, which is seen in 40 to 50% of aplastic anemia and inherited bone marrow failure, and we falsely attribute to acquired aplastic anemia. So we should look upon the other aspects also. There may be absent PNH clone, 50 to 60% aplastic anemia lack clones. We should get TCR, VB, Delta, LNC, and DEX scanf. What PNH not mandatory. I'll just discuss this thing also. Large PNH clone treat as PNH aplastic anemia versus classic aplastic anemia. Many times we have a difficulty in differentiating these two. I'll just discuss these two aspects also. Post-IC clone emergence, clone expand post-immune suppression. So we confuse with the LAS versus PNS progression, hypocellular MDS mimicker, age less than 40 with a clone, inherited versus acquired. Now, what is this TCR beta analysis or DEC immunofluorescence? I don't have any experience. I just got through one of the literature. So they they help us in differentiating the immune-mediated aplastic anemia versus the autoimmune destruction. So TCR-VB analysis is there, detects oligoclonal T cell expansion, and if it is there, shows it's the autoimmune destruction, that is acquired aplastic anemia. Similarly, immunofluorescence, there is a basically in the immune-mediated apoptosis, it is there. Generally they are present in the cytoplasm. When there is a basically translocation to the nuclear, it lead it in the basically they are present in the cytoplasmic localization in the CD34 cells, and if they are translocated to the nucleus, it is pathognomic of a T cell cytokine signaling. So that means we are dealing with the acquired aplastic anemia, and we can combine that utility. Many times we confuse whether we are dealing with a classic PNH or the PNH clone in aplastic anemia. Likewise, in this case, we had a very large clone. So when we are dealing with a classic PNH, hemolysis is the first finding, while in PNH clone in aplastic anemia, pancytopenia is the first finding. Clone size is generally more than 50% granulocytes in the classic. However, PNH clone commonly have a less than. However, in this case, we had a very high clone. So LDH is very high in classic PNH, but normal in the PNH clone. The bone marrow normal hypercellular in the PNH, while hypocellular in the aplastic anemia. The reticulocytes is very high in classic PNH, low in the PNH clone in aplastic anemia. Therapy we know that both have a different therapeutical implications, even the prognostic implications also. So coming to the case 7, what once looked like a shadow of a malignancy turned out to be a reflection of life's resilience and wisdom, transforming a moment of a fear into a story of relief. A 19-year-old present to the emergency department this was actually a child whose father was a dear friend of mine. So he came with a sample that his child has been diagnosed as a ALL, and the child was running with a fever, abdominal pain, extreme lethargy for last 7 days. However, the patient had a Pancytopenia. There are some these kind of cells which were misinterpreted as a blast. So we were very sure because the were kind of hugging the RBCs. They like we sometimes we call it kissing our kissing cells. So they have abundant floating cytoplasm, compact protein, chromatin. So still we did the flow cytometry, which we can see that it is a polyclonal. So many times these scenario, in fact, I've encountered at least 10, 15 scenarios like this. And it makes me very happy that I'm telling the patient that you don't have a leukemia. You just get the viral serology done. There are some clues, the nuclear regularity, the heterogeneous population, there's some cytoplasmic features which you've seen, the nuclear prominences. They are also in the reactive. There are one to three. However, the lymphomas will generally have a single prominent nucleolus. There are various aspects are there. We can do the viral serology also. So we can do the flow cytometry also, and these morphology alone in actually make an error in 20 to 30% of these kind of scenarios. So coming to another last case, in the microscopic battlefield of a pseudo and true deception stood strong until evidence allowed the truth to prevail. So this was a 30-year-old female who presented with a generalized lethargy, weakness, along with a peripheral neuropathy for last 4 to 5 years. So physical animation, pallor with a moderate splenomegaly, no history of loss of appetite and weight. The clinical suspicion initially was megaloblastic anemia. In fact, went to the MPN also, because we looked upon, this was also published in the BMJ. So we looked upon the bone marrow in this 30-year-old female, lot of Gaucher cells, the storage cells. So that ruled out everything. The megaloblastic anemia, the myeloproliferative neoplasm, the megakaryocytes were okay. There were no proliferation of the megakaryocyte, because I just want to put upon the emphasis, because in myeloproliferative neoplasm, you may commonly get the pseudo-Gaucher cells. However, through the past staining and through the morphology, we can differentiate them. And similarly, in myeloproliferative neoplasm, you will get a increased megakaryocytes, that to a typical one. So you can do the molecular test also. So generally, the Gaucher cells have a GBA1 gene mutations. In adults, they are generally in the type, especially the type 1, and they lack neurological signs. However, this patient had the neurological signs also. So these are the morphological mimics, Gaucher versus pseudo-Gaucher. Pseudo-Gaucher, I told you, seen in MPN, especially the CML, lymphomas, malaria, the megaloblastic anemia also can have a pseudo-Gaucher cells appearance. We can do the past stain, we can do the enzyme assays, the hematological overlap is there, because pancytopenia is there in both, whether it's a Gaucher cell or whether it's a megaloblastic anemia, whether it's a MPN. However, and sometimes what happens in the early stage, the marrow infiltration is not there. We may miss them. So if we have a suspicion, clinical suspicion, we can do the enzyme assays, we can do the NGS done. The clinical non-specificity is there because splenomegaly is present in both of them. Again, imaging traps are also there. So take-home message, pancytopenia is a syndrome, not a diagnosis. Peripheral smear remains the first diagnostic clue. Bone marrow examination is indispensable. Multiple disciplinary collaboration is essential. A systematic diagnostic algorithm prevents errors. So final concluding line, behind every pancytopenia lies a story hidden within the marrow. The challenge of the hematologist is to understand the biology that silences them and finding the key between the smear and mind that connects them. So I don't want to forget to put my acknowledgement to my patient, to my teachers, Dr. Tatakat sir, Dr. Kavita ma'am, Dr. Renu ma'am, Dr. Pati sir, Dr. Seema ma'am. So they have all guided me, my seniors. The list is very long. My colleagues' list is very long. I've served in 2 institutes. My residents have taught me. My residents have been blessed to have a very good residents also. Again, blessed to have a very phenomenal lab assistants, lab technicians who have been doing a basically background work. I'm just a person with a screen in front of screen, but behind the screen, there are a lot of my entire team is there. Thank you.
Thank you, Dr. Ankur Ahuja. Fantastic lecture, fantastic cases.
Thank you, sir.
Very well. Thank you so much. And now I request all of our discussants to please put the hand raise signs so we can start a question session with Dr. Ankur Ahuja. In the meanwhile, once the hand raise signs keep pouring, and let me take some questions from the audience. There is one question from Dr. Negasa.
Uh-huh.
Uh, the viral cause of pancytopenia is common. When to suspect bone marrow failure in low resource settings?
So, if we start with the basics now, the viral cytopenias, if we are dealing with a hepatitis C virus or so we look upon the LFT. We should not forget the doing the biochemical test like the LFTs to look upon the hepatitis C virus or the B virus manifestation. We should not forget about to see the peripheral blood smear. The peripheral blood smear I have found to be superbly good, and I've get so many clues in that. You'll get the viral reactive lymphocytes. So these are the major clues. If we even if we are not doing the bone marrow, or even if we don't have a flow cytometry. However, if we have a facility of a flow cytometry, in viral induced changes, we'll get most of the cells are T cells, and many times there is a reversal ratio also CD48. However, the clonality is not there.
Thank you. Another question is from Dr. Yimon Tent. What are the clinical clues which help differentiate between aplastic anemia from hypocellular MDS?
So the clues are basically the MDS and the hypoplastic MDS and the aplastic anemia. Now the hypoplastic MDS is seen either seen in the elderly age, and now we are as the we are progressing, we are seeing some pediatric cases also. In generally young adults, we don't see the hypoplastic MDS condition settings. There will be recurrent transfusions in the clinical settings. If we say the especially the PRBC transfusion in the MDS. However, it's very difficult to prove them clinically, but we have a findings again in the right from the peripheral blood smear, where we find an isopyclocytosis in the RBCs. We'll find the anisopyclocytosis in the platelets. If we are getting that, it is more of indicating towards the MDS part. We are getting the cabot ring cells. We are getting the basophilic scripting, again indicative of the MDS part. We are getting dyspoetic neutrophils in form of a hypogranulation, monolobated, or the hypogranulation, again indicative of the MDS part, sir. So if we just remain to the basics, CBC or the peripheral blood smear will help us.
Thank you. Another question is about the most practical diagnostic algorithm for evaluating pancytopenia in resource limited settings.
So in resource limiting settings, because we have also seen those settings in some of our postings also. So the first part, we all have a automated hematology analyzer, or even if not automated, semi-automated is there. So for the CBC, the MCV, the reticulocyte count, even if it is there, not there in the equipment also, we can have a very cheap manual retic count also done. So I've already indicated in the slide that it helps us in ruling out so many. If reticulocytes are reduced, they are seen reduced in megaloblastic anemia, MDS settings, and aplastic anemia. They are increased in autoimmune settings, the viral settings. So the MCV generally high, but less than 110. More than 110 is more common in megaloblastic anemia. Honestly speaking, I've never seen more than 110 in any other settings except the vitamin B12 deficiency. The CBC histogram is very helpful. We can see those peaks. In fact, it's a very long lecture. Otherwise, CBC histogram can tell many findings in that. So we have a CBC, we have a peripheral blood smear again, mentioning about the dyspoisis part, the anisopyclocytosis part, the dyspoisis in the neutrophils, the anisopyclocytosis, the basophilic stippling, the cavot rings. All these can the type of the cells we are getting. We should look upon the edges also, peripheral tail also, which you look upon in the dysbiosis in the WBCs. So even the platelets also, the in the MPN myeloproliferative neoplasm, the generally the platelets are large, they are hypogranular. So all those settings clue are there. So CBC, reticulocyte count, and if bone marrow can be done in a, I'm sure bone marrow can be done in the resource constraint settings. So we have a these cytochemistry. Why I have put this cytochemistry is for the resource constraint only, because these cytochemical stains like PAS stain, Pearl stain, the MPO, the NSE, they can rule out most of the things actually.
Thank you. Dr. Gurpreet, you have a question?
Good evening, sir. Thank you, sir. First of all, I would like to thank Ankur, sir, for this beautiful lecture, and I've learned a lot from him. So, my question to sir is that in the era of molecular hematology now, increasingly we, run to MDS fish panel, we run to NGS. So, how do you think morphology will still stay relevant in these cases of pancytopenia in the coming years?
Uh, Thank you, Gurpreet. Again, thanks a lot for your all help and your support, your cooperation when we are posted together. So I still put an emphasis upon the morphology. In fact, we are the ones who are leading the our cytogenetics or the molecular one, and they are very grateful to us also for giving many of the clues. So morphology is not to be forgotten. Actually, it is the base. In fact, in one of my lecture on the 5th April in the MHE is based upon that only. So most of the answers will be there and then that. But morphology of the WBCs, the blast, the type of the blast, the appearances of the blast will definitely help us. If we are getting, likewise in my first case only, the entire morphology, despite of that patient was non-vegetarian, there was a very strong clinical history of a lymphoma, malignancy, but the we were stick into the morphology part, those morphology, and we could able to diagnose. I still remember that patient face because he was totally had a मतलब kind of a was given a kind of a diagnosis that you are suffering from a non-Hodgkin's lymphoma on the basis of that symptoms, and that patient was actually very down. And when we told him the diagnosis, the megaloblastic anemia, and that too because of a small worm, so he was very happy that it's a treatable, and the patient went off very happily. So morphology has a very impactful role. In fact, if we are strong in morphology, we can reduce a lot of our burden to our cytogenetic specialist and the NGS molecular specialist.
Thank you. Another question, Dr. Gurpreet?
Yes, sir. Like, especially I want to ask Ankur, sir, that sometimes hypocellular MDS and aplastic anemia, I mean, we always find that it's very difficult. I mean, we don't see too many blasts. The cellularity is less. Even on CD34, sometimes, it also picks up dyspoetic megakaryocytes and all. So, what should we rely on in the morphology to differentiate an aplastic versus a hypocellular MDS?
Yeah, thanks. Again, it's a very common setting. I still remember one of our case in our AIMS Delhi. So again, labeled as a aplastic anemia, which came out to be just after 2 months came out to be having a acute myeloid leukemia. So the if we go to the retrospective on those cases, I we because we learn from if not our at least somewhere if we miss something, so we should learn from those things whether we are basically miss thing. So the reticulin stain will is very helpful if we are finding the increased reticulin, because aplastic anemia generally have a 0 grade, 0 to 1, but the hypercellular MDS will have a one at least one to 2 grade. So reticulin stain is very helpful. We should do CD34 and CD117, which rule out the basically ellipse, that is abnormal localization of immature precursors. Generally, we know that these blasts or these stem cells are seen in the peritavicular region or the perivascular region. So we should get these stain done, and we should look for the internal control in forms of a vessels also, whether they have worked or not. And if they are more than 3 to 5 spaces away from the paratrabecular or the perivascular spaces, then these are labeled as a ellipse, and they are actually nothing but hypocellular MDS, and they are prone to develop acute myeloid leukemia. So we have a reticulin stain, we have a CD34, we have a CD117, and not to be forgotten, CD41 and 61 stain also, so IHC stain also, which actually, because in MDS we are getting a hypolobated megakaryocyte or monolobated and very small sometimes. So if we are just looking upon the He hematoxylin and eosin stain, we tend to miss them. And if we are getting CD41, 61 stain, in fact, 2 days back only we got such case, the hypocellular MDS, and there was typical 2, 3 megakaryocytes were there, which in H&E stain, it was definitely not appreciable, and there were ellipse also.
Thank you. Any other question, Dr. Gurpreet?
Thank you very much, sir. Thanks a lot, sir.
Thank you.
Yes. Dr. Rashmi Kushwaha, your question, please.
Thank you, sir. Congratulations, Ankur sir, for a very nice presentation and the wonderful cases. And
Thank
it
you,
was
ma'am.
very informative. And
Ma'am.
my question is very much similar to Dr. Gurpreet's question. Like we also have a case recently around a 60-year female with presenting with pancytopenia, although the marrow was quite cellular with granulocytic and erythroid precursors were normal in morphology and maturation. However, there were few dysplastic megakaryocytes. But we got the refined biopsy, it was totally aplastic, except for few clusters of megakaryocytes which were hypolobated. There were no ALIPs on 34 or 117, and we have sent the sample for NGS now, waiting for the result. However, I have not done the reticulin. So after listening to you now, probably tomorrow or day after, I will go and put the slide for the reticulin stain. So this hypoplastic MDS is definitely a problem, especially when aspirate is not showing significant dysplasia.
Yes, ma'am.
Another thing is the osteopetrosis. So patients with osteopetrosis also come with pancytopenia. So we had this case of 16-year female who had pancytopenia, and the refined biopsy showed the thickened trabeculae and the features of osteopetrosis. So probably these were the things which I wanted to just
Yes,
put
ma'am.
across, and they were there in your presentation also, sir.
Thank you, ma'am. The osteopetrosis case always click on my mind, because I still remember that patient who was roaming around last 3, 4 months from one place to another, and the emphasis upon the IT spaces, the other features, and just a simple X-ray was required to get the diagnosis. And when we asked for that, because broad bony trabeculae, and sometimes actually even in generally osteopetrosis, the age pattern is the most closely morphological mimicker is the PMF. However, the age doesn't matter. Osteopetrosis have a younger age, and the PMF is a elderly age. There is a difference. If we are getting a woman bone, it is osteopetrosis. If we are getting a laminated bone, it is most like a PMF. We get a reticulin stain, which will definitely high in PMF. We get a atypical megakaryocytes in the PMF. So morphological mimicker is there, but however, clinically they are not mimickers. But osteopetrosis, I always put the emphasis that please look upon the bony trabeculae. Please look upon the bony trabeculae. Always, because that was a learning lesson for us.
Yes, definitely. Thank you, sir.
Thank you.
Thank you, Dr. Rashmi. Dr. Shilpi, you have a question?
Good evening, sir. Thank you for the insightful lecture, and the cases were very informative. I also wanted to share a case. We encountered a 60-year-old lady with pancytopenia and splenomegaly. Clinically, all the viral markers, liver causes, infectious causes, everything was excluded, and we did the bone marrow. So in the bone marrow also, morphologically, there was nothing much. Cellularity was also okay. So we did flow cytometry, in which we found around 3% of clonal kappa-restricted B lymphocytes, which were 5 negative, 10 negative, 23 negative, 25 negative, 38 negative, 103 negative. So we suspected, we gave it as suggestive of SMZL. So on the basis of even molecular analysis of the bone marrow aspirate did not reveal anything. So the clinician gave BR 6 cycles, and after the 6 cycles, the pancytopenia subsided. The spleen also came back to normal size. So similarly, sir, what you also said that many a times the bipolar cells and hairy cells can be deceptive. So just wanted to emphasize and ask your experience on such cases, because very few morphologically it was I could not identify those 3% of abnormal B lymphocytes in the peripheral blood smear, but the flow cytometry was able to detect that. Your experience on such cases, sir?
Yeah. So I totally agree with that, and basically it's sometimes very difficult when the cells numbers are very low. Honestly speaking, I always put an emphasis, please get the bone marrow done to have a larger emphasis, and because in bone marrow we have a lot of things. If not flow cytometry, at least we can do we have a morphological H&E look, we have a reticulin stain done, because definitely reticulin is likely, because I've experienced 3-4 SMZL cases which like your cases, and they get a very confusing look also. So, but in bone marrow biopsy, they are very clearly evident. They will give you the strong evidence that yes, I'm SMZL with a CD20, CD33, the reticulin stain, the kappa lambda IHC. So they have a very important. So bone marrow again, I feel key in those source constraint also we can do it. Thanks
In
for
our
sharing your
case,
case.
sir, the patient she did not give consent for biopsy after the aspirate. She said, "Bas abhi mujhe kuch nahi karana hai."
Okay, no issue.
That,
No issue, but it is in aspirate, yes, in flow cytometry, then we don't have any other aspect except the flow cytometry. But also get the molecular, in your case, it was negative. But in my 4-5 SMZL cases, in all of them, the deletion of chromosome was there. So,
okay,
which is again very indicative. And I just want to put an emphasis that chromosome deletion 7, because initially one of my colleague my asked ki, I hope we are not dealing with a MDS also. So one should this thing look upon that also, because chromosome 7 deletion is not in the MDS. It is seen in the even I also got confused with that. So it is seen in the it is very common in the SMZL.
thank you, sir.
Thank you.
Thank you, Dr. Shilpi. Finish all the questions from the chat box. Let me look. Well, so there are no more questions in the chat box. Anybody wants to ask any other question over here? So, well, sir, in that case, sir,
Thank you,
thank you
sir.
so much for the wonderful lecture. That was really wonderful cases, wonderful discussion, and a wonderful question answer session. Thank you so much. And
Thank you,
again,
sir.
tomorrow at 11:30 a.m.
Yes, sir. We'll meet tomorrow. Thank you, sir.
I thank all our discussants over here, as well as all the audience who have participated in this webinar. Meet you tomorrow 11:30 a.m. Thank you.
Thank you,
Thanks
sir.
a lot.
Thanks.